Welcome, everyone. I think to ensure we have time for our conversation on the panel, we're going to start. So on behalf of the International Network on Hepatitis and Health in Substance Users, I'd like to welcome everyone to this event. The INSU backup team, if you could just share the presentation for me, please. And then just to welcome everyone, and we'll go on to share mode. Some little housekeeping to start. If you can please make sure that you've muted your phone. And this event is really commemorating World Hepatitis Day, which will be on the 28th of July. And we have been asked by people who can't join the session for us to record it. So we ask your consent to do so. We also share the presentations that are linked. When you're having any questions or comments, please post them in the chat, and we will have an engaging question and answer panel at the end. We will also be doing some polls, so please participate in those as well. And if you'd like to raise awareness around viral hepatitis, please use the social media platforms that you can see the tags at the bottom as well for various social media platforms. So just a brief note about INSU. The International Network on Health and Hepatitis is a global network, and we're focusing on improving the health of people who use drugs. The membership includes clinicians, researchers, nurses, also members who identify as people who use drugs with lived and living experience, and also organizations from around the world. You'll see we have representation in 53 countries. And within Kenya and South Africa, the membership is growing. We have three broad areas of focus, particularly around knowledge exchange, education, and advocacy. And this activity bridges several of those. And this particular activity builds on a new project that we're embarking on, which is an advocacy storytelling project. It was intended to work with people with lived or living experience of drug use and or viral hepatitis C, and with local consultants with expertise in storytelling, help people to build a capacity to use their lived experience for impact, involving workshops, one-on-one sessions, and the opportunity for them to share their stories and engage. In South Africa, the project is well developed. We have 3 participants. And in Kenya, the project is following in a step sequence, and there will be 6 participants who will be developed to develop their experience as stories for advocacy. What we hope to do next is just give you an overview of the partners for this event. So from Kenya, we're really happy that the Kenyan government, and particularly the Ministry of Health, are supporting this event, as well as the National STI and AIDS Control Program, and in partnership with networks of people who use drugs, the National Kenyan Network, as well as the regional network from Kilifi. From a South African perspective, it's great to have this event endorsed by the National Department of Health, the National Department of Social Development, the South African National AIDS Council, the Central Drug Authority, and it's being held through support through the TB HIV Care and the South African Network of People Who Use Drugs. And this event is part of a program funded by the Open Society Foundation. So you'll see that this event has an hour-and-a-half virtual. We are coming to the end of the housekeeping. We'll have 2 brief interviews, overviews by a representative from the Kenyan Department of Health and then a South African counterpart. We'll then go into the interesting aspect of storytelling. We'll hear some insights into what stories are, and then we'll hear some people's stories. And then a little bit later towards the end, we'll have a panel discussion where we'll encourage participants to share some questions that they would like people answered. So just some particularities around admin. Please keep your microphone on mute. We are encouraging people to use the chat functions on the Zoom group. You will be able to just make a chat question to everyone, and we'll come back and answer them in due course. So the first speaker is Dr. Nazila Ganatra. She is the head of Department of National Strategic Public Health Programs in the Ministry of Kenya, who will be giving a brief overview of viral hepatitis among people who use and inject drugs in Kenya. Thank you.
Good morning, everyone. Thank you very much, Andrew. I'll just start screen sharing and then immediately to my presentation. All right. Is my screen visible?
Yes, we can see it perfectly, and your sound is excellent. Thank you. Over to you.
Thank you very much. So, as Andrew has introduced me, my name is Dr. Nazila Ganatra. I'm the head of the National Strategic Public Health Programs. And one of the programs under the National Strategic Public Health Programs is the National AIDS and STI Control Program. The rest are the National TB Program, National Malaria Program, and the National Vaccine and Immunization Program. And today, I'm going to give a brief overview of the hepatitis program in Kenya. So the Ministry of Health envisions micro-elimination of hepatitis in Kenya, and this is in line with the global health sector strategy on hepatitis, which provides a roadmap towards the elimination of viral hepatitis as a major public health threat by 2030. That is by decreasing the incidence by 90% and the mortality by 65%. Of course, more recently, the Global Health Sector Strategy 2022-2030 also aims to look at elimination of AIDS, hepatitis, and STIs by 2030. And these goals are aligned to the SDGs. Hepatitis in Kenya. Kenya is an endemic nation for hepatitis B and hepatitis C viruses. Hepatitis is disproportionately distributed within counties and the population. The Kenya population-based HIV impact assessment, KENFIA 2018, estimates the prevalence of hepatitis B as being 3% among the general population. And the hepatitis C prevalence in the general population ranges between less than 1% to 4%. And these were demonstrated by various studies which were carried out. However, the hepatitis C burden among people who inject drugs is quite high. It ranges between 16 to 22%. And this, again, was established or determined by the various studies which were carried out, including the more recent SHARP study, the test and link to care, Mwakazi and Mwasia et al. Currently, there are about 27,000 people who inject drugs in Kenya. So what is the Ministry of Health doing in order to achieve our micro-elimination of hepatitis C? First is the policy aspect, whereby the Ministry of Health, through the National AIDS and STI Control Program, has developed the first ever national viral hepatitis guidelines, as well as the standard operating procedures. This clearly outlines the algorithms which can be used for testing and, of course, the treatment guidelines as well. Currently, we're also developing the viral hepatitis strategy. We also know that in terms of hepatitis B, we have the vaccination, which has been included in the Kenya expanded program for immunization, given to infants at 6 weeks, 10 weeks, and 14 weeks as a pentavalent vaccine. We are also identifying and linking to care those who have been found to be positive with hepatitis C as well as hepatitis B. So in terms of hepatitis C, we do the antibody testing. Once found positive, and this is normally done in the needle syringe exchange program and the methadone medically assisted therapy sites. Once the antibody positive is found, then we recommend for a PCR test, which is currently done at the National Public Health Laboratories, and it is done at no cost. The treatment for hepatitis C is normally provided using directly absorbed therapy, and this is done at the medically assisted therapy sites, that is the MAT clinics, as well as specific PWID drop-in centers. The drugs of choice, which is a pangenotypic, is Epclusa, which is a fixed dose combination of sofosbuvir as well as a velpatasvir drug. This treatment support is provided through the Global Fund and is available for about 1,000 clients. Currently, to date, for Hep C, we have about 350 clients who have been treated. Further, the program has also, for the identification as well as linking to care, has adopted the peer-led model, whereby peers are participants who are recovering from substance use disorders. And these peers are selected through a nomination process at the harm reduction centers and trained on basic harm reduction strategies as well as HCP. So these peers are very important as they assist in doing home visits, support to adherence in treatment, and are also involved in creating awareness in the communities, as well as awareness basically in very important days like such as the world events, World Hepatitis Day. They also help in engaging external partners such as the law enforcers, considering that the PWIDs are a population which is basically also found in the prison settings, and therefore that linkage to care and follow-up is also done by the peer-led model. Thirdly, the ministry also embarks on improving awareness, advocacy, and education about hepatitis. And this is done annually every year in July during the World Hepatitis Day. They also develop and disseminate the IEC materials on hepatitis, as well as training the peer educators and healthcare workers on hepatitis. So all these strategies are aimed at our main goal, which is the micro-elimination of hepatitis in the country by 2030. Thank you very much, and over to you, Andrew.
Thank you very much, Dr. Ganatra. I didn't ask you to put on your camera at the beginning, but hopefully your bandwidth will allow so during the panel discussion. Thank you for that presentation. Now we'll move to South Africa. It's fantastic to hear how Kenya is really leading the continent in terms of integrating viral hepatitis services for people who use drugs. Now from the Department of Health in South Africa, Dr. Vilakazi-Nhlapo leads the national hepatitis work, who's going to just give a summary of the South African context and approach. Over to you, Dr. Vilakazi-Nhlapo.
Thank you, Andrew. Good morning, colleagues. Let me share my screen.
So we can hear your audio. We're still waiting for your presentation to come up.
Thank you. Can you see my screen?
We can, if you just put it into presentation mode, please. Perfect. Over to you.
Okay. Thank you. I'll just switch on the video for a few seconds so that you can see me. Thank you. As I've just been introduced by Andrew, my name is Kgomotso Vilakazi-Nhlapo from the National Department of Health in South Africa, responsible for the integration of TB, HIV, and leading the viral hepatitis program. Viral hepatitis is a significant problem in South Africa. When we look at hepatitis B, we've got a seroprevalence of surface antigen of almost 6-7%, which is an estimated 3.5 million people in the community. With regards to hepatitis C, we've got a moderate burden with seroprevalence estimates from 2.4 to 3.8% amongst key populations. And within the general population, it is estimated that we've got about 600 people who are actually infected with hepatitis C. We've got a concentrated hepatitis C epidemic among people who inject drugs. A study that was done in 2017 has shown us that the HCV viremia prevalence ranges from 28% in Durban to 93% in Pretoria, with about a third of those who are injecting drugs being co-infected with HIV in Pretoria. Viral hepatitis is one of the notifiable medical conditions in our country. In 2016, the World Health Assembly endorsed the elimination of hepatitis as a public health threat by 2030. South Africa committed to those WHO 2030 targets by developing and approving the National Clinical Guidelines and 5-year Viral Hepatitis Action Plan in 2018. The guidelines recommend that the country adopts hepatitis B birth dose for newborns within 24 hours after birth, increase awareness, diagnosis, and treatment for hepatitis B, especially in antenatal clients by screening them for surface antigen and providing management as per the results of that screening. And also to introduce the HIV, STI, viral hepatitis, triple L elimination. We also are going to embark on a one-time campaign to screen all healthcare workers for hepatitis B, vaccinate them for hepatitis A, hepatitis B, and treat those who need treatment. And it will also be important that we integrate screening and vaccination at entry into clinical service by these healthcare workers. We've actually started the screening for hepatitis B in a forensic chemistry laboratory staff. This was done in 2019, and our National Health Laboratory Service has got a policy that is ongoing for screening of their staff. The other priority within our guidelines is to expand access to management, that is screening, diagnosis, and treatment of hepatitis C in people who inject drugs and other key populations. This should include needle and syringe services for the period. The challenges that we face, that presentation of hepatitis is non-specific. I mean, it's like abdominal pain, nausea, vomiting, which can be any other cause. We also have issues of poverty and inadequate sanitation, which is responsible for most cases of viral hepatitis, especially A and E. We've had outbreaks from E recently. Previously, we didn't have any guidelines for screening and management, but we do have now, and we have embarked on ensuring that we implement these guidelines. We have insufficient guidelines on HIV, Hep B co-infections and our ART guidelines that are focusing mainly on Hep B, and there isn't much information on hepatitis C. We're currently revising our consolidated ARV guidelines, and we're ensuring that hepatitis C management is included in these guidelines. There's also insufficient awareness amongst healthcare workers, including our clinicians, on hepatitis. Therefore, we've got underdiagnosis of this condition. There's also lack of information on data on viral hepatitis burden of disease, because we do not have routine surveillance of hepatitis in the country. Whatever information we get is from various studies that have been done around the country. And again, treatment is expensive for hepatitis C, the DAAs. So it is clear that without testing, we will not be able to meet the 2030 goals. So the testing gap is quite great. Why? Because large numbers are undiagnosed. As I said, there's underdiagnosis. And if they're diagnosed, they are diagnosed late because they are symptomatic. There's also insufficient testing of key populations. All provinces in the country, all 9 provinces have got GeneSped for TB, but only 3 provinces are performing molecular testing for hepatitis, which is 2 of the big provinces in the country plus Mpumalanga. So how do we reduce hepatitis C? We do by testing, of course, harm reduction, counseling and services, safe injection and infection control practices. There's also a need to increase general knowledge among patients and clinicians and referral to HCV care and services, as HCV is often not prioritized, and actually care is not offered at a primary or healthcare level, and even in our district healthcare facilities. So patients are usually referred to our tertiary institutions. Treatment is also important for hepatitis C. The goal is to achieve a sustained virologic response and delay or stop progress to more serious liver damage. So we know that the aim of treatment for hepatitis C is to cure, and all hepatitis C infected individuals are candidates for DAAs because it has been shown that there's more than 90% cure rate. Currently in the country, we've got 2 DAAs that have been registered by SAPTA, but unfortunately they haven't been launched yet, so we are unable to access them. Those DAAs is Epclusa and Havoni. Currently, for patients to access treatment, they have to go through Section 21. So persons who are tested and for hepatitis C is persons who have ever used or injected drugs, recipients of blood transfusions, patients who have ever or are receiving long-term dialysis treatment, persons with known exposure to hepatitis C, like healthcare workers after needle stick injury, recipients of blood or organs from a donor who later tested HCV positive, all people who are living with HIV, patients with signs or symptoms of liver disease, or children born to hep C positive mothers. The test is to do the antibody test, then if it's positive, then to do the PCR. So how do we advise patients who have viral hepatitis? Patients who have hepatitis should be advised to avoid alcohol because it can accelerate cirrhosis and end-stage liver disease. They should be informed about the present risk for transmission with sex partners, so they need to use condoms. Sharing of personal items that might have blood on them, such as toothbrushes or razors, can pose a risk to others, so they should be also advised against using this. Cuts and sores on the skin should be covered to keep from spreading infectious blood or secretions. Donating blood, organs, tissue, or semen can also spread hepatitis C, hepatitis B to others. So in our country, actually, our blood transfusion services actually do check regularly for hep C, B, and HIV. And it's also important to inform our clients that hepatitis virus is not spread by sneezing, hugging, holding hands, coughing, sharing, eating utensils or drinking glasses, or through food or water. And it's important that patients should join a support group, especially if they are on long-term treatment. And people in high-risk groups should be tested, especially people who inject drugs and other key populations. We also need to implement HPV-ACV screening strategy as in our national guidelines. HIV programs should also include guidance on the management of hepatitis B and hepatitis C. We should also not forget about TB programs, especially for PWID, as we know that are also susceptible to hepatitis. And of course, routine ANC should also ensure that there's guidance on hepatitis. We need to expand our hepatitis B and C treatment services to secondary and district hospitals and include in the basic package of care for NHI. And hepatitis B and C diagnosis and basic workup can also be done at the primary care level, especially if we need to increase access to management of hepatitis B and C. So uncomplicated hepatitis B can be treated at a primary level, and patients with hepatitis C that need referral to tertiary level for further management can be referred to tertiary, but those who are uncomplicated can also be managed at primary healthcare level. It's important that we have good coverage of needle and syringe services and OST for PWID. We know that we've got a range of tools that are available to support this implementation. Thank you.
Thank you, Dr. Vilakazi. I think it's also good to be reminded of the key prevention elements so we all are on the right page for our knowledge. And while we're getting ready for the next presenter to bring up her presentation, which will be Mathapelo, great to hear Kenya's moving forward on implementing the policy and South Africa having the policy framework. And we clearly have a lot of way to go, and hopefully we'll hear how storytelling can help us on that journey. So over to Mathapelo Mofokeng, who's a very experienced storyteller in using people's stories around health and social issues for change.
Cool. Thank you, Andrew, and good morning to everyone. As Andrew mentioned, my name is Mathapelo Mofokeng. I'm a writer and a storytelling workshop facilitator. My presentation will be 25 minutes long and will cover the areas that are listed on this page. We'll be looking at a couple of examples of personal stories that have been used for advocacy. We'll have an opportunity to do 2 polls. I'm hoping that it can be participatory and we can use the reflections from the the results from the polls for us to unpack some of the things that come up. We'll be discussing what makes an effective advocacy story. We'll be looking at how organizations, it will be broad, but we'll be talking about how organizations can source stories. And then we'll have 1 or 2 examples, peer stories, which will be shared after my presentation. Okay, so before I begin, I'd like to mention that even though this event is about viral hepatitis, for the purposes of sharing examples of effective advocacy stories, we've drawn on examples from other areas so that you can see how personal stories across a range of experiences have been used to advocate for the improvement of the lives of people. To start off, we'll begin with a short story example, which was created by the International AIDS Society in partnership with the Children's Radio Foundation, which is an organization that creates opportunities for young people to share their experiences using radio. And then after watching the story, we'll have an opportunity to participate in a quick poll around Cleopa's story. It will be shared shortly.
Family of 4, I'm a youth reporter. My name is Cleopas. I'm 23 years of age. I live in Quito in the copper belt of Zambia. I'm the second born in a family of 4. I'm a youth reporter living with HIV. I've lived with HIV for the past 5 years now and I've faced a lot of challenges. I've faced stigma from my friends in several ways. Others would laugh at me, others would not want to sit next to me. People just hate you because you are HIV positive. Even finding a job, it's very hard. In the copper belt, when finding a job, you are requested to produce a medical report where you show your health status, and when they discover you are HIV positive, you are unable to get a job because you are not well fit enough to work in the mines. In my communities, there are no support groups, so to get that support, I travel 350 kilometers just to get the support group. That's in Lusaka, the capital city of Zambia. That's where people accept me and treat me as who I am. I'm now in Lusaka from the Copper Belt to meet my friends for the youth programs, and I'm excited. I've joined the group Agents of Change, where we interact, we learn things, we talk about HIV, and I dream of the world of people where they will stop discriminating people who are living with HIV and AIDS and treat them right because we're all equal. In Lusaka, that's where I work with my fellow youths for radio productions where we interview people and talk about HIV and other related diseases. When I'm at the support group in Lusaka, I feel welcomed because those people have accepted me as who I am. They treat me equally. I would like people to stop discriminating and stigmatizing people who are living with HIV. I would love the government and the world leaders to conduct more campaigns and to create more support groups for people who are living positive, to have a positive living. I believe to change the world, as I can go back in Quito and take the information to those people who don't know about HIV and AIDS and to stop the stigma. I have the courage to speak up because I'm not ashamed of myself.
Cool. I hope everyone was able to to pick up on the video. So now we're going to do a very quick poll, and basically the poll will be conducted anonymously. You'll each have 30 seconds to respond to the question, and after the responses are gathered, we'll speak about the results. And basically on your screens, there should be a prompt that comes up. And the question is, from Cleopa's story, why do you think personal stories are important in the advocacy space? Select 3 statements you most agree with. You'll have 30 seconds. So personal stories have the potential to challenge the stereotypical images and reduce stigma. Personal stories can lower audience resistance to new ideas and stories. They can evoke empathy, they can spark curiosity, can motivate, reduce stigma, or illustrate complex systems. Select 3 statements that you most agree with. Okay, about half of you have answered. We'll give you at least 30 more seconds for the other half. Okay, 70%. I'll give you another 30 more seconds. Okay, I'm going to end the poll now with 75% having participated. And yeah, from the poll, I'm not sure if everyone can see the results, but it seems like 85% of you all agree that personal stories have the potential to challenge the stereotypical images and reduce stigma. Secondly, 62% of you felt that personal stories can motivate those who hear them to take positive action. After that, 46% of you felt that personal stories can evoke empathy more than information solely presented through facts and statistics. So yeah, thank you so much for participating in the poll discussion. All of these statements are true, and in the next slide, we're basically going to unpack each of the statements and just elaborate on them more. So on the first point, which is that stories challenge the stereotypical images and can reduce stigma, there's very few opportunities, as has been discussed in the past presentations and the presentations before me. There's very few opportunities for people living with viral hepatitis and all who have experience with using drugs to speak, to be heard, and to control how they're represented. Personal stories allow for connection and relatability, which means that listeners and audiences can see parts of themselves and their experiences mirrored back. This process of seeing oneself creates an opportunity for the listener, the person listening to the story, to reflect and to contemplate. And it shifts the experience from private to shared, making the issue a public reality. The second point being that stories can lower audience members' resistance to new ideas and solutions. Stories can spark curiosity on the issue and motivate those who hear them to take positive action. So the experience that I was highlighting before around the reflection, stories allowing listeners to reflect and allow themselves to be mirrored, it has the potential to discourage counter arguments from an audience. So it has it has the potential to shift in a listener's approach from arguing, like a counter argument, to one of curiosity, to one of inquiry, and to one of question asking. Onto the third point, which is stories can evoke empathy more than information solely presented through facts and statistics. So though fact-based information plays a role in advocacy, the statistics, the data, and the argumentative pieces are often, they lack context, in that the information lacks a personal experience, it lacks a journey, it lacks themes, and it lacks a human if it's just presented as a statistic, which makes it challenging for the listener or the audience to relate. With all the challenges in the world, we've become very desensitized and distant to issues that don't directly pertain to our lives. So statistics alone are no longer enough for people to comprehend an issue and to empathize. Through data, and by data I mean figures and statistics, though they play an important role, the personal story behind the statistic is what will drive the message forward. In a book written by Jeff Bloomfield called Story-Based Selling, he mentions findings from the London School of Business, stating that people have different levels of information retention based on how information is delivered to them. So he found that when people hear statistics alone, they retain only 5% to 10% of what they hear, compared to when stories are used to convey the same information, retention jumps from 65% to 75%. So that's to show the power of storytelling compared to just fact-based information alone. When stories are shared, people are able to recall stories, and the information is more memorable than statistics. Onto the final point, which is that stories can illustrate, personal stories can illustrate complex systems and overlapping issues. This is to say that one story has the potential to subtly present other economic, structural, social factors impacting people's lives. So again, just going back to the presentations before me, issues such as poverty and lack of sanitation was highlighted in terms of in terms of viral hepatitis, issues around viral hepatitis. That's what storytelling can do. It can help you see the other economical, social factors impacting people's lives. And I'd like to also just state a finding or quote by a journalist by the name of Walla Jorgensen, who said that among 101 written articles that won a Pulitzer Prize for journalism between 1995 and 2011, nearly 2/3, which is 63%, used personalized storytelling to draw their readers to the article or to illustrate the social issue. So we're going to have another poll, and this will be the second and final poll. But basically the next poll question is a question for you all reflecting on Cleopatra's story and reflecting on the statement that stories can illustrate complex systems and overlapping issues. So again, it will be anonymous and you'll have 30 seconds to a minute to respond. And the poll question is, even though Cleopatra's story was about the stigma and discrimination he experiences in his community, what are the other issues apparent in his story? From the list below, pick the issue which felt most apparent to you. This is a single choice response. Choose the one that felt most apparent to you. Is the issue lack of education on HIV and AIDS? Is the issue mental health? Is it inadequate public transport? Unequal HIV care support systems between cities? Is it around climate justice, discriminatory employment hiring processes, food insecurity, or community violence? Okay, 55% have responded. I'll give you 30 more seconds. Okay, and I'll be ending the poll shortly. Okay, so feedback. So most of you felt that, okay, that the most apparent issue was around lack of education on HIV/AIDS. So 34% of you felt that that was the most apparent issue. 24% equally felt that it's the most apparent issue was unequal HIV care support systems between cities, and 24% felt that the most apparent issue was discriminatory employment hiring processes. So yeah, this poll, I mean, this was just really for you to be able to see that even though the topic can be about, you know, in this, for the purposes of showing a strong advocacy story, we shared a film around HIV, but if it was around viral hepatitis, you would have the opportunity to explore other apparent and social issues that are impacting people's lives. Right, and then onto the next slide, I'll be talking about what makes an effective advocacy story. The first point being that what makes an effective advocacy story are stories which center on those affected. So when organizations create opportunities and platforms for storytelling, it's important that the voices of the people affected be central to the narrative. When stories are told by those that are affected or those that are closest to the issue, it brings an authenticity to the story because it's been told by the own storytellers. Well, it's been told by the storytellers in the storyteller's own language and dialect, from their own memories, from their own personal experiences, highlighting the moments and the reflections that they are most passionate about and want to emphasize. When it's told by someone who's closest to the issue, it allows for more of an emotional appeal without the storyteller having to entertain or perform. It's just naturally authentic and feels real. The second point is that messaging and stories which age well. So stories need to age well. Effective advocacy stories are ones that age well. And when we say age well, we mean that stories that can stand the test of time, because the values and societal norms will change. The world is constantly changing, but you need to be able to create a story that will stand the test of time and will age well. How? Well, some of the things that you consider to ensure that you're creating, that your organization is creating a story that will age well. The first thing to consider is your advocacy story inclusive? And does it showcase the diverse experiences of people? By diverse, I'm referring to age, gender. Does it have the stories of immigrants? Does it have stories that reflect different sexualities, different races, different classes, backgrounds, cultures, disabilities, etc.? Secondly, to ensure that your story ages well, you need to recognize that, well, it's important to recognize that the messaging and the call to action is not separate or isolated, but in unison with other lobbying efforts for the health and access to services. So the messaging should, even though not in an overt way, but it should support other advocacy messages around access to health and services. Thirdly, another way to ensure that your advocacy story will age well is that even though the advocacy, all advocacy stories focus on challenges, the story will stand the test of time if they promote the dignity of the storyteller and if they display empathy for the storyteller's journey, their experiences, and their community. Lastly, another way to ensure that stories age well and will stand the test of time is to focus on positive change. So either the change that the storyteller experiences for themselves, or positive change that they hope to see in the world, which also gives listeners or an audience an opportunity to become a part of. Other elements that make up an effective advocacy story are keeping it simple and short. So the example that we saw was about 2.5 minutes long. And it's important that they're short so that you don't infuse too many messages in the story, so that the story is not cluttered and so that the message is clear. The advocacy stories can go anywhere up to 5 minutes. 5 minutes is good. Another element to consider is to have clear takeaway message. So consider, what is the intention of the story that you're sharing? Is it to raise awareness? Is it to debunk myths? Is it to reduce stigma? How do you want the audiences to react? What action do you want the audiences to take? Effective advocacy stories have a clear takeaway message or call to action, which is aligned with the organization's goal. And sometimes, often, it would be helpful to leave the audience with practical steps or actions that they can take to contribute positively. Another element is it's engaging. So even though it's presenting, even though it's informative, and even though the stories are informative and to support evidence-based research, they still need to be compelling and engaging. So include suspense, have surprise the audience. Don't make it too predictable. Display people or the storytellers as layered and complex people. Make them relatable, make the story relatable. Include unforgettable moments, use descriptive language and paint a picture for the audience. Include tension, conflict, a challenge. Make sure we know what the storyteller's desire is and how far they are to reaching their desire or meeting their need. And lastly, effective advocacy stories are easy to follow. The story structure needs to be easy to follow. It needs to be one that an audience is familiar with. Even if you follow the traditional beginning, middle, and end, you can switch things around, but make sure not to confuse an audience. Okay, and now we're going to have another, with all the information that I've shared, we're going to have another opportunity to watch another story, which is 2.5 minutes. It's another story on HIV, but we're sharing this story in particular so that you can see an example of a good advocacy story.
Siliso, Dina 24 years old, ndihlala West Bank in Cape Town. I live with my mom. She's the only parent that I have. Ndaba pregnant in 2013 and then was diagnosed with HIV. So support ndifumene kumama wam, and then ndamxelela boyfriend yam tatomntanam ba ndi-HIV positive. Emva koko emveni koba ndimxelele wavele wanyamalala wahamba. Into ebendiyinqwenela uba mayitshintshe apha kule ndawo ndihlala kuyo eWest Bank is that akho kliniki apha enonceda abantu like umuntu uba unesifo se-HIV positive. Like mna ndihamba ikliniki eseKhayelitsha, so i-treatment yam ndiyithatha khona, ngamanye amaxesha ndithatha iteksi. Ngamanye amaxesha ndiye ndingabi nayo imali, funeke ndihambe ngeenyawo zam. So ke ngoku indlela ibande ekufuneke ndihambile, and ke andizude ndithini, andizuhlala endlini because iipilisi zam bubomi bam. Basically, the thing that is different, it's the friendly receptionist, the pool table, the music that they played, and also this is the room where I meet my group. I'm in my room with Akko, my little daughter, my first priority in my life. Lena ipilisi yam ndiyithatha ngo-8 qho ebusuku. I-support apha ekliniki ndiyayifumana, but when it comes to mother and child, yikho lo support leyo abasiniki, so yeyona nto engicinga uba iyashota apha ekliniki isikakhulu. Ngoku ndisepakini nomntanam uAkho sizodlala. Le ndawo ibalulekile kum ngokubana uAkho ndifuna uzomdlalisa, ndimbonise uthando endinalo ngaye, and also like abe free, like abe joyful, abe happy, and enjoy uba secaleni kwakhe.
Sorry, everyone, we just realized that the video wasn't sharing and that you only heard. Brooke, can we please play it again just with video? Okay, but yeah, okay, we are short on time, but yeah, sorry about that. I hope just through the parts that were in English that everyone was able to follow.
Sorry, I can share it again. I'll just need to reshare my screen again to make it work.
Are we fine on time?
We're quite short on time. So I'm so sorry about that, everyone. It seems that the audio worked, but not the film. Mathapelo, perhaps if you could just quickly explain the film, and we'll move on to the next slide.
Sure. Okay, so it's about Cindy, who is living with HIV. And her story is really about, similar to Cleopatra's in that she doesn't have access. She lives in Khayelitsha, which is in Cape Town. She doesn't have access to support groups close to her home. So in the story, she talks about how far she needs to travel in order to access treatment, and also to be close to the peer support groups that she relies on. Okay, so the next thing I'll be talking about is just the impact of storytelling for advocacy, looking at the impact on the storyteller, organization, policy, and health outcomes. For the storyteller, so sharing a personal story may result in self-discovery, self-empathy, active participation, improved communication skills, and increased confidence for the storyteller. It also allows the storyteller to learn more information on the issue that they're impacted by, the services available, their rights, so that they can adequately support their communities and their peers faced by the same challenges. So it allows the storyteller to become advocates themselves and educators within their communities. In terms of an organization, including storytelling in your advocacy efforts, as mentioned, can help organizations quickly identify the key topics and the changes in the work that they're doing. Organizations are able to gather accurate, up-to-date stories which reflect the day-to-day challenges and nuanced experiences of the client, so that your work is informed and your efforts are informed by what is really happening. This information can be used internally and externally. Externally, as we've been discussing, for advocacy efforts, so narratives can facilitate the information processing and provide value and emotional appeal in the information. So using narrative information to support evidence-based research, the story behind the statistic, as I've mentioned, but also for internal strategies. So narratives can be used to inform organizational interventions, campaigns, and goals. By using the stories, you can create responsive and relevant program activities, which are shaped by local realities. In terms of impact on policy, it's important to remember that listeners hold their own understanding of the world, prejudices, assumptions, perspectives, unconscious biases, hopes, ideals, and experiences. The attitudes that surround policymakers, decision makers, and government will influence what they hear and how they respond. Stories have the potential to subtly change their beliefs and influence how they listen, but it's a journey, and it's a complex one, and it needs multiple interventions to support it. So again, multi-component interventions are supported, and it's more that the story needs to form part of a larger campaign and intervention. It can't stand alone. In terms of the impact on health systems, I'll give a personal reflection. I work with an organization that hosted weekly outreach activities on adolescent sexual and reproductive health themed dialogue events in a youth clinic waiting room. The outreaches were organic, and the clinic operations continued while the clients waiting to be seen by nurses or doctors participated in outreach activities, sharing their opinions and their stories about sexual and reproductive health rights and experiences. The clinicians in the background continued their work duties. They listened to the dialogue as if it was a radio playing in the background. But when we interviewed them on the impact of the dialogue activities that were happening around the space in the waiting room, they each said that the dialogue events, the stories that they heard, helped them increase their personal awareness and understanding of young people's specific needs when it comes to health services and adolescent sexual and reproductive health. I just want to mention one depth interview that was conducted with a nurse. She said in her words, "I have gained a lot from these children. We took HIV for granted because we thought people knew everything about HIV, but they don't." And this happened organically in the background. These are just stories that this is something that she learned from listening to the young people talk about their experiences and the experiences around access to sexual and reproductive health services. And finally, onto the last part of this is how can your organization source a story? The first thing is to form partnerships and relationships with local partners. Ensure that the values and the missions are aligned with yours and that they have an active and ethical relationship within the communities that you're working with. Another thing is to have an explanatory conversation with potential storytellers on the approach. So what's the methodology? How will it be collaborative? And how will it be aligned with the storyteller's goals and the story and the message that they're most passionate about and the story that they want to tell? Determine which type of story is being created. Is it a life story? Is it a slice of life? If it's a life story, it will include a series of events from their childhood right up until their present day and the circumstances in which they find themselves in. If it's a slice of life, it just zooms in on one important defining moment. So for example, if it was a slice of life, it would be a moment where a clinic experience, let's say, where the storyteller was perhaps turned away or mistreated by a healthcare practitioner when they're trying to access services. The third thing is to put in place an agreement between the storyteller and the organization. What is the compensation involved for the storyteller? What's the conversation around consent? Consent is not fixed. It's not fixed. It's negotiable and it can change. Determine the platforms where the story will be shared. Discuss how long the stories will be shared for and whether there are any parties who will reuse the story. Determine who the custodian or is responsible for the stories. Is it the communication department or is it the project manager, project coordinator? This will depend on the human resources available on the organization. And lastly, determine which platforms the stories will be used in. Are they going to be used for external organization documentation, such as funding proposal, annual reports? Are they going to be used for conferences? Storytelling is in a collective space like this one, helps individuals realize and demonstrate connections between their individual struggles and larger structural injustices. As mentioned earlier on in the presentation, stories are able to cut through complex issues. So there's an opportunity to use stories in events and conferences where there's an intersectionality, when intersectionality exists. Will you be using the stories for organizational comms? So for newsletters and social media to reach a diverse range of people depending on your subscriptions? Or will it be for audio and video streaming platforms such as YouTube? These mediums, audio and video, they do require budget to produce, and yeah, they do require budget to produce, but they are worth considering because media can act as a catalyst in awareness raising and in gaining general public support. There's a lack of reliable evidence on the use of media interventions to influence health policy making. But if you consider the wide reach that, say, a commercial or community radio station has, for example, you can reach audiences in remote and isolated places. Remote and isolated places, and yet are affected by the issues that you're lobbying for, and you wouldn't necessarily have access to, people you wouldn't have access to. So that's it. That is the end of my presentation. We'll now be moving on to peer stories. Okay. Perhaps we listen to one story. We were going to have two stories. Perhaps we listen to one for the sake of time. We can, okay, just one thing, sorry, these stories.
Hello, it's Brooke here again. We'll start with Sizwe's story, so I'll play that one. And we also have Richard available as well, so I'll just see if he's still keen to talk. But okay. I will just play Sizwe's story first. If you'd like to introduce him, I'll get it lined up and hopefully you'll be able to see the screen this time.
Okay, okay, cool. So Sizwe is one of the South African storytelling participants. And is a peer educator at community-orientated substance use program. In his stories, he will address needle and syringe programs, which is a core component of eliminating hepatitis C, as mentioned earlier in the presentations.
My name is Sizwe. I'm a 31-year-old from Pretoria, South Africa. I'm a father of two beautiful boys, 8, and the other one just turned 12. Papa, where's my phone? I have to get my boy's smartphone. I am taking donation. I am a substance user. Heroin is my drug of choice, which is locally known here as Nyaope. I was an intelligent teenager who loved to laugh and raised mostly by my mother. I was also easily influenced by my friends. At 14, I was already experimenting with alcohol. The following year, I was smoking weed and selling cigarettes in school. In high school, I became very curious about what my friend was feeling every time he was high on Inyao, which was a popular drug with the young kids at the time. That curiosity led me to smoking Inyao as well. Initially, I was afraid of it. It took me almost 2 years to be addicted to Inyao. 2010, I experienced withdrawals for the very first time. I was in Madrid. It was an exciting year in my country. We were hosting the FIFA World Cup 2010. I lost my father, and 2 days later, my son was born. I was not ready. I fell deep into addiction. I was a young father who was conflicted, running away from his responsibilities and accepting them. At the same time, I lost my father. At the time, I felt I needed him. The mother of my kids suffered the most during this time. I hate you, is what she said to me. I left her to fend for herself and the boy. I found comfort in escaping to this fictional world that Nyaope created, where I have no responsibilities and I felt like a failure. Started to even have suicidal thoughts. One night in 2017 in my bedroom, which is in the back of the main house, I injected a bag of Nyaope, which I had bought from a different dealer than my usual guy. It's advisable to stick to one dealer that you know. After injecting though, I immediately started to vomit uncontrollably and repeated all over my room. I started sweating. I thought I was going to die. I managed to find my room key, but somehow I couldn't open my bathroom door. I saw a call from my nephew who was in the house. By the grace of God, he and my neighbor heard my cries and came to my rescue, ultimately saved my life. After the overdose back in 2017 in my room, I decided it ends here. I already had many failed stints in rehab, but I discovered myself in rehab. That was the very first time I heard of the term harm reduction. I was an injector, and these people were talking about legal services, which was a taboo subject to me at the time. Even the police services, one time I was arrested, were like, no, these people are promoting people to use drugs, So they even didn't understand the importance of. I had never heard of any organization that gave sterile syringes to people who use drugs. The clinics weren't even doing it, they're not even doing it now. I knew I had to find out more about harm reduction. And the only way was to find out one of their sites, which was in social media. I even paid someone with drugs to show me exactly where the harm reduction site. I arrived and attended a group on safe injecting method. In one day, I learned how to inject my drug safely. 3 months with the team from COSAP, I had reduced the amount of bags I had smoked from 5-6 to 2 bags a day. I volunteered to get into their opioid substitution therapy, which is the methadone. I often ask myself, how has harm reduction services being in my community impacted my life as a person who uses drugs? Harm reduction has allowed me to take good care of my body as a person who injects, to confront my mental health issues. I am happier with my life. Harm reduction services have assisted me in my quest to change my life and have a relationship with my 2 boys. I now have bring harm reduction services to people who use drugs by being a peer. Thank you so much.
Hello, it's Brooke here from INSU. I just wanted to check in with Andrew here in terms of timing, and then we'll also get our next speaker up, who Mathapelo will then introduce you to, who's Richard from Kenya.
So I think as so much of the session is around storytelling and hearing people's experiences, we would like to see if Richard is able to give his presentation, and we'd just like to also have an engagement of the panel. So we'd request to extend the session to continue till 1:15, so 15 minutes longer than previously planned. We started a little bit late and some of the presentations have been longer than anticipated, and we've had some technical issues. So we understand if people can't stay for the full time, but that will be our plan. So Brooke, can you just confirm if Richard has got tech and is able to chat? I know that you're working with Mercy around that, and then I'll hand back to Mathapelo.
Yes, I believe that Richard is.
Yeah, good morning.
Excellent. Good morning.
Good morning. My name is Richard Wanjohi. I'm 42 years old. I've been using heroin for over 15 years. Heroin is my drug of choice. But before using heroin, I used to use weed at high school. After finishing high school, that's when I started using heroin. First, I started by smoking, then I graduated to injecting, whereby I thought if I started injecting, I would use less heroin by injecting, and I would save a lot of money, whereby I would be having that challenge of looking for more money for heroin. By then, there was no needle and syringe exchange program in Kenya, so we used to share a lot. We used to share everything from syringes and needles to every injecting paraphernalia, water, tourniquet. Gradually, my tolerance increased, and now I became a heavy user. As time went by, now we used to share heroin from one syringe. Would then share among ourselves. Then came the program of methadone in 2014. That is where I discovered that I had hepatitis C, because it was mandatory for everybody to be tested for hepatitis while joining the methadone program. Luckily, after 2 years down the line, treatment came, and I was lucky that I was among the first people to be enrolled in the treatment. I successfully finished my treatment after 3 months, and I was declared virally suppressed after some retesting. I think that's all because of time. Thank you.
Cool. Thank you very much, Richard. Thank you also to Sizwe. Yeah, your stories were highly personal and required a lot of vulnerability and bravery. So we thank you for taking the time to share them with us. We firmly believe that by amplifying your voices, we can help raise awareness of viral hepatitis and other harms related to drug use, and how we can break down the barriers of stigma and discrimination. So thank you again for sharing your stories. I'd like to now hand back to Andrew for our Q&A.
Great, thank you very much. So I think if there are various people who are going to join the panel, I'd like them to put on their cameras and just start by introducing themselves. So we'll start first with Koketso, Mokubane. If you could introduce yourself, please.
My name is Koketso Mokubane. I'm the community linkage officer for SANPUD. Thank you.
Great, which is the South African network of people who use drugs. Welcome, Koketso. Then also we've got Dr. Wamda Abuelhassan. If you could introduce yourself, please, and a bit of your background.
Hi, good day. My name is Wamda Abuelhassan. I'm a gastroenterologist. Currently working in Tembisa Provincial Tertiary Hospital. Prior to that, I worked at Paraguanan Hospital. And we started having a hepatitis clinic back in 2006, where we were treating hepatitis C patients. Yeah.
Wonderful, thank you for joining us. And then the other clinician that'll be joining us is Dr. Mohammed Mwakazi from Kenya. If you could introduce yourself, please.
Good morning, everybody. I'm Mohammed Mwakazi, a clinical officer working in Kenya, Mombasa County, coordinating mass activities, harm reduction, and viral hepatitis screening, treatment, and care. Been working very closely with people who use or inject drugs in medically assisted therapy, together with managing the comorbidities that are associated with drug use, injecting drug use. Thank you. I'm happy to be here today. Thank you.
Great, thanks very much. So we would also encourage the other people who are on the panel or presenting earlier just to also put on their cameras, and encourage people who might be in the audience to place any questions they have into the chat. I think just to start, looking with Koketso and Dr. Abuelhassan, Dr. Wamda, just between the two of you, I have some questions to start us off. So Koketso, someone with lived experience of drug use and or exposure to viral hepatitis, what's been your experience of sharing your story with a healthcare worker or a clinician?
It depends on the health. It depends on the healthcare worker that I'm sharing my story with. I'd say I've been one of the lucky ones because where I received treatment, I got all the support. The staff there were properly trained. They were able to support me. Even today, they are still supporting me. but I've also interacted. I also have bad experience with other healthcare workers from other sides, because from my own family, my aunt, she's a healthcare worker, and I've had bad experiences with her being a healthcare worker. So it depends on the person, and it depends if the person got sensitized, they are trained enough on us as people who use drugs, because we've been generalized. Everywhere you hear people, they just say, we are just key populations, but even in every state, they say key populations, but if you check and we look at things correctly, none of us as people who use drugs access healthcare facilities on a primary level, because we know we get stigmatized, we get discriminated, because no one understands us. No one understands where we come from.
Thank you. So interesting to hear that some people are receptive of your stories and your experience and are able to help if they've been trained and engaged, including around drug use and viral hepatitis. But in other contexts, there may not be an opportunity for the stories to be shared because of experienced or fear of discrimination and stigma. Then over to Dr. Wamda. Many people with viral hepatitis do face stigma and discrimination, which can affect their willingness to access services, which Koketso has just spoken about, particularly with hepatitis. How do you think doctors might make their clients feel more comfortable and open just to break down those barriers?
I think doctors have really a great role in making their clients getting to care by building trusting relationships with those patients, and then at the same time allocating times for them to tell their stories and alleviate their fears. And it's actually really spending time informing the patient about the disease and taking away any misconceptions by giving them information about this disease and what to expect. I find this really helped us a lot during our clinics. The other thing was the setup of our clinics, for instance, was really encouraging patients to come. So I remember back then in 2006, when we started treating hepatitis C patients, we were treating them with peg interferon and ribavirin, with the multitude of side effects that the patients had. But we started with a small clinic, and patients used to sit in a lounge where each one of them shared their stories and created like a support group between themselves. And they would really come and tell you, like, I feel like so-and-so doesn't look like herself today, or so-and-so didn't come so far, so till now, and you need to call her. And it was really a great experience. So mostly really addressing deficits in HCV-related knowledge can really ameliorate this stigma and increases the patient's engagement in their treatment. We also had helped couples kind of break into each other that they were kind of having the disease, and I had couples really coming for treatment together and support each other. So really it was a great clinic during that time. And the most important thing I find is really trusting relationships.
So that's really wonderful to hear, that doctors can provide information, but also can provide the space to support people to share the disclosure issue and also share stories amongst peers. I think that's a wonderful role that clinicians can play. And that's almost supporting community engagement and advocacy as groups of people who are accessing a service. So now if we move to the Kenyan kind of colleagues, if we can ask perhaps to you, Dr. Mwakazi, when doctors are involved in storytelling and their roles in service delivery, are there ways that stories have been used in your clinic to either increase demand for medication-assisted treatment, OST, or hepatitis testing, or adherence onto hepatitis C treatment? How have stories been part of the work that you do also to improve quality of care in Mombasa?
Thank you so much, Andrew. In Kenya, we are happy that storytelling and the journey towards viral hepatitis, especially hepatitis C treatment, has really grown from where we had none. And this is because of the model that we are utilizing in Kenya, whereby the methadone clinic, MAT clinic, work very closely with the community service organizations who actually do the client engagement in the community, and then the drug dens, which work very closely with the MAT clinic staff and the doctor there to ensure that we are able to hold to reach the client even at their drug den, in terms of sensitizing them on hepatitis treatment, in terms of sensitizing them on the issue of getting substance use disorder treatment and management. This has really assisted and helped, whereby there is a collaboration within the clinic and within the community. We have been able to get clients, and the earlier clients who are initiated on a treatment, like I introduced myself earlier, I'm coming from Mombasa. The coast region is the one in Kenya, is the one that has been affected so much with drug use and hepatitis, viral hepatitis among these people who inject drugs. And this has really made us have ways and strategies to ensure that the clients access treatment and get treatment through reaching to them and getting the peers from amongst themselves, those who are injecting drugs, those who have been treated or have been diagnosed with hepatitis C and have been put on treatment, have been able also to be peers. Some of them have been recruited by the CSOs as peer educators and outreach workers to be able to mobilize their own peers so that they can be able to access the viral hepatitis treatment. And another key thing that has also improved on the uptake of services for viral hepatitis is the policy from the government of Kenya through NASCOP, whereby there is availability of medication, there's availability of screening, there's availability of diagnosis, and all this is being offered to the client at no cost. So this really has improved uptake. It has really improved the way the clients have been engaged, especially the clients who subsequently have been enrolled in the substance use treatment. So with this, it is very essential to ensure that storytelling keeps on going on, especially through peers to peers and capacity building of those peers by the medical or fraternity, to ensure that when they are having peer-to-peer talk, they give facts and be able to relay information that is there and demystify the myths that are there. That is the model that we have been implementing in Kenya, and with that, we have really seen that there's improvement in viral hepatitis treatment, especially hepatitis C. Thank you.
That's wonderful to hear about the work of clinicians to support the implementation of policy, and you can have that ability to work with communities, work with peers to be able to increase access to services, and particularly supporting the peers to have the accurate information around hepatitis C prevention and treatment. So I think, now moving to Richard, as someone who himself is a peer worker in Mombasa. Can you explain how you use stories to connect with your peers or other people who use and inject drugs that might be at risk of hepatitis C or who might be living with hepatitis C? What are your thoughts or experiences, Richard?
As a peer educator, I was as a peer educator and a living success story. I'm able to connect with them because they see me as one of them, as a person who has undergone the same experience as them, and I use my story to motivate them and to encourage them to seek hepatitis C services. And I also sensitize them on the modes of transmission, the risk factors that are associated with sharing, injecting paraphernalia, and the prevention measures.
And any tips you've got for other people of how to really connect with peers to share stories?
Any tips? Come again.
You said that you're able to reach your peers, your other people who use drugs because you can link with them. But do you have any tips or suggestions for other peers of how they could do that better?
Or I would advise them to come out with their story so that to break down the myths and misconceptions that are surrounded by the hepatitis C. And by speaking up, they'll encourage the other peers to come out from the closet and to start living positively.
Thank you. So supporting people to have information, meet with people who link, and just be that ability of trustworthiness of someone who understands the realities that people have been through. And now I think we've spoken about the realities and engagements between community members and clinicians. Now I would like to shift a little bit towards policymakers and people within national health programs. So then just Dr. Ganatra, from your perspective as a policymaker, also someone in the Ministry of Health, what role or what could be done to help amplify the voice of people's stories, the people who are exposed to viral hepatitis, the people that are needing treatment and access to harm reduction services? What's your approach or your experience of really enabling that and making those spaces for change?
Thank you very much, Andrew, for that question. So when it comes to stories and amplifying the voice of the community, what we could actually do is to encourage, critically collaborating and addressing the community needs, including the healthcare needs. And what the organization, or basically the ministry, tries to do is actually to provide a platform where nobody or people are not afraid to speak about the challenges and to speak up about the stories. And especially in the national strategic public health programs, we deal with not only hepatitis C, but we also deal with HIV, we deal with TB, and these are all public health concerns which are stigma related, and therefore we really need to have community champions out there who call in people and really talk to their peers to encourage them to come forward, either seek treatment, seek diagnosis, and also just being there for them and ensuring that they have the support that they need. We also aim to provide prompt feedback in case there is some questions from the community, some challenges, and the ministry and the program, the national STI program, can be able to come forth and provide prompt feedback. We also would like to give specific, specific and consistent information so that the people can reach out in due time and be able to get assisted. So those are the kind of, repeating the stories over and over, being consistent with the information. For example, we can say that the treatment is free, the diagnosis is free, the testing is free, and we keep reiterating that over and over. So the people or the clients who feel stigmatized and fear to come out actually, because of this consistent information, now try to take the step forward so that they can come in front and we could be able to assist them. So yeah, that can be some of the ways in which we could do that. Additionally, what we could do is actually engage in the community leaders and community-based organizations, keep them in the training, always provide probably training and, constantly giving them technical assistance. And also, not only that, we should also see that while we are providing this technical assistance, this trainings, we also track the progress. Is it really helping, or what are the challenges, or what are the gaps, so that we can therefore come in and then plug in with that information. We also help the communities come forth, providing their problems, telling us the problems, and also giving us some of the solutions they think that we should be able to, come forth, or what the ministry should be able to come up with. Of course, as the previous speakers had alluded to regarding the communication on the policy aspect, we know that this it's a complex process and it doesn't happen overnight, so it takes time. So therefore, we have to have those kind of multiple engagement pathways and communication channels always open, so that we can have a clear indication of how to move forward, community-based, people-centered approach. Thank you.
So clearly, the Ministry of Health has such an important role. You've highlighted it can create platforms and spaces. It can, I think most importantly, ensure people aren't harmed. And I think the safety responsibility, so that if people do tell their stories, they're not arrested, they're not, because that in both of our countries is a big issue. Highlighted this ability of linking and enabling the collaboration of where stories can be shaped, and just ensuring that as a government department are responsive to what you hear from the stories. I think that's a wonderful kind of summary of the role in your context. I'd like now to draw on some of the comments that have come from the chat and on what you said about the Department of Health or Ministry of Health's role, to Sizwe, who also, is someone from the community, people who use drugs. And we've heard that sometimes we're not going to specify Kenya or South Africa, but in many countries, the departments or governments don't necessarily implement the policies. It can be quite hard to come forward as someone engaged in a criminalized behavior. Sizwe, in your experience, what can help and give people the courage to, really come forward and demand services that are in policy, and also, come forward for care? Sizwe, what's been your experience, or what would you like to share with the group? I believe we have Sizwe on the line. If not, I don't know. Mathapelo?
Sorry, it appears that Sizwe's dropped off. I think he might have had some technical issues.
Mathapelo, from your perspective, from what you've heard and the engagements that you've had with the storytellers, in the consultant process and this project, do you want to take that discussion any further, and then ask, we'll move on to someone else for their perspective.
Yeah, I think really from, just in terms of my interactions with Sizwe and him being a peer supporter and working within the organization, and me getting a sense of the work that he does, he has spoken a lot about, first he wasn't sure, just outside of his story, where stories or how stories can be found, how stories can be sourced in the first place. And he was speaking about sitting at the registration desk, being the first person that clients interact with. And when they come, he asks them their names, their age, their surname, if they will disclose. And I was telling him that, Caesar, that is the story. That is the beginning of the story. That's where the story begins. I think if organizations, I think when you've worked within an organization or within certain issues for a long time, you assume that you now understand and that you know. But I would say, and the conversation that I had with Caesar was just to remain curious about himself, to remain curious around the stories of the clients that are coming forward. The story is when someone comes forward and they disclose their name and their surname and what they need and their age and where they're from. When a client comes to a clinician or a nurse seeking treatment, when the clinician asks, like, how are you feeling since I last gave you your treatment, since I last saw you, how are you doing today? That's where the story is. That's where the stories are packaged, in the everyday interactions within an organization. And I think, I know there's a lot of work, and it's a forward momentum, and there's a lot that needs to be done on different levels. But to pick up on the stories aren't going to come packaged. They're in the everyday. They're within the organizational activities, and that's where they can be sourced.
So it's also about being open and asking the right questions, I think, is what you're also encouraging people to do, and to have the time to develop the trust so people can give you that experience. We know that time is often an issue, particularly in a busy clinic, to really give people the time that they need to develop trust and share story. I just see that someone from Taib from Mombasa was just saying how they've got a robust program of integrating health services at their drop-in center, and that they've used storytelling in their engagement with government to help increase access. I think that's good, just showing that what we're putting here is not just theoretical, it's actually happening. And I see something from Koketso, as a representative from the network of people who use drugs in South Africa, just highlighting how there can be sometimes selection of which stories get portrayed, so it only fits in a certain lens. And I think that's also idea, because the people in power have the ability to censor which stories they feel more appropriate to portray and which they don't. And I think that's coming back to this issue of people being able to tell the stories as a community of which they believe are important, and not what's dictated by people or organizations of power. Dr. Kgomotso Vilakazi-Nhlapo, from your perspective, have you seen any change of how stories have maybe shifted the way things have happened in South Africa around viral hepatitis? We know in South Africa we've got a great policy, but we haven't yet implemented our policy, largely because of funds or limited political will. Have you seen any change? Do you think storytelling for advocacy could make an impact? What would your little couple of thoughts be from what has been said up to now?
Hi, Andrew. You were cutting, but I'll try to respond. I think, storytelling does increase understanding and insight on what patients go through. This is like first-hand information on what they're going through. This plays a huge role in the advocacy process, because this is gives a face to the condition. As we all know, knowledge of hepatitis is very low. Some people are not even aware of the condition itself. I had an interview last week, Monday, on hepatitis in one of our radio stations, and the questions I got were like, what is hepatitis, and when did it start? Is it a new disease? That's the amount of knowledge that it's clear that we don't have in our population. And some who actually were diagnosed positive were saying that the doctors couldn't actually didn't know how to manage the condition. So they find themselves in limbo, not knowing where to go. So yeah, it is very important that we do have the stories, people tell the stories, and then this will actually even help us in policy development when patients come, because there's this saying that's nothing for them without them. This will also help us to have more buy-in for them, have them being part of the development of these policies, and get even more funding, because funding is also our challenge in the country, because this is like new guidelines. So yes, this will definitely stimulate policy discussions, which may lead to prioritization of the disease, with support, of course, from civil society. I still feel like patients' organizations in the country need to be even more vibrant and stand up more so that they can be noticed. Thank you.
So great to hear the recognition of, the need for advocacy and stories. And I really am checking my chat, communicating with Brooke, but I'm aware that we've already gone over time. And I think it's been really fantastic to hear the great work being done in Kenya and how there's been scale up and how there's been the use of advocacy and sharing with peers. And we're really excited that there will be this group of people that'll be part of this INSU project. So congratulations to the people in Kenya and all of the support. The South African panelists and the clinicians, thank you also for your time and your reflections, and hopefully this will help us think a little bit more of how to use stories moving forward. Forward, I would like to